And I wish us all an interesting morning. As you can assume, there's also some people from our MCI network, people who are currently managing the risks and the situation in Innsbruck, and who are really curious to hear from those countries in the Southern Hemisphere who have already managed one winter time, how you did, what are the best practices. And beside all the academic debates here, this has extremely huge impact what we are doing here. So thank you very much to everybody. And now back to Francesco.
Thank you, Siegfried, and good morning, good evening, wherever you are. A good session to you all. This is the second event that we organize together with our friends at MCI. The premise to this event was the first one, which we ran a few weeks ago, that really set the scene in terms of the reasons underpinning the design of policies and technology. So we looked at concepts and frameworks to try and find a logic into the necessity and proportionality of the measures introduced so far to combat COVID-19. And we had a great group of experts that look at it from a societal perspective, including legal, epidemiological, economic, and sociological perspective. Now, today we follow the series with a great set of presenters that all pretty much participated to the special issue that the Value in Health Economics and Policy Group network put together. And the special issue is now available online. And I just heard yesterday that we are approaching fast also its paper version. I will, of course, let you know when that is when it's going to happen. The journal, of course, is Journal of Health Policy and Technology. That was really our focus in the special issue. And we covered 28 countries plus also papers that were not country related that we covered in the previous session with MCI already. So tonight we have a great set of presenters. We wanted to cover a lot of ground, so we asked them to keep the presentations to 10 minutes max. I will interact with them on time in the chat to remind them if they need to come to a closure. We have Professor Manuel Garcia Goni from the Universidad Complutense de Madrid, who is a health economist, colleague that has worked with us for a long time. And of course, also a colleague of not only me, but also Siegfried and MCI that has joined enthusiastically this COVID project, which we'll talk about Finland. Marcello, who is doing his PhD actually on these topics and has been contributing to a couple of papers, and he will present the Italian perspective. Jonathan Tritter, who's one of the guest editors of the special issue, who will present on Norway. Matthias, who is the founder of Synergus and now also launching a new initiative in Sweden and in the Nordic countries, and he will present on Sweden. And Richard Fordham, who is a professor and based in the UK, will actually give us a very interesting perspective on the situation. His work and his contribution is coming in, let's say, at the end of the special issue, and we really hope to increase the collaboration going forward. After these presentations, of course, we will have the contribution of a wonderful panel, which I will present in due course. Now, I will like to introduce you again, Professor Manuel Garcia-Goni, and the floor is yours for the Spanish case.
Okay, thank you very much, Francesco. Thank you very much, Ifrit. Thank you very much, all. I'm very happy to be here today in this seminar. It's a pleasure, especially because I was at the MCI a long time ago, and I met there also Ayman and my very good friend Francesco, which is always a pleasure to be invited by him to anything that he's organizing, and he's organizing many things. So it's a great pleasure. So I'm gonna present today the case of Spain for this what has happened. Please let me know if you can see my screen. Everything is fine? Okay, thanks. So the point here is that we have had this terrible situation everywhere in Spain and everywhere, and oops, let me see. Okay, so this is a joint work. First of all, let me introduce this is a joint work with Josefa Enriquez, Eduardo Gonzalo Morox, and Francisco Paolucci and myself, and we are presenting what happened in Spain in the first months of this pandemic of COVID. This has been terrible. This has been a terrible situation in Spain and everywhere. It's clear that it is not only in Spain but everywhere. It's an unprecedented crisis, and maybe you can have to go back 1 century to the Spanish flu to see something similar, but the situation in terms of many things is completely different to what happened 1 century ago with the Spanish flu, which was Spanish just because of the name. But anyway, in terms of epidemiology, it was a really important case also for the case of Spain. We were one of the first countries suffering in Europe, suffering this pandemic, and that was something that was very important for us because we were not prepared. That wasn't, in my opinion, that wasn't an excuse then in February or March or April. It is not anyway for sure now an excuse, but we have identified that we have several problems in terms, for example, in public health or prevention, because we didn't do our work in order to try to basically fight against this type of virus. We have implemented exceptional measures. The most important ones have to do with the lockdown and with the reduction of mobility for everyone, and that was huge. Maybe we did it a bit late because we started in mid-March, and by then we had more than 200 deaths in Spain, and the first death was in January. But at least we did it, and that was very severe, even more severe than in many countries, and longer than in many countries. Okay, and basically there was a huge problem with the mobility, huge constraints to the mobility, and huge losses in the markets in the economy world in Spain. Let me tell you something about the national health system in Spain. We have a universal system which is free at the point of use, mostly, except for some pharmaceuticals with prescriptions. But one of the main characteristics of our system is that we have 17 regions and the autonomous communities and 2 autonomous cities, and each of those autonomous communities have their own health service. So in a sense, even if we have one Ministry of Health, in the sense and in terms of functioning, basically in practical terms, we have 17 different ministries of health for each of the different autonomous communities. And that is going to be very important because many times each of those is going to have different measures implemented. And therefore the effects of the pandemic has been slightly different for each of those at the beginning and at the end, but not in the middle, because what happened is that we had centralized all the competencies in health because of what we named a state of alarm that was called in mid-March. So basically all the lockdown was centralized for the whole Spanish population, although at the beginning, before March and after June, basically each of the different regions were doing something slightly different. So full competencies in provision of health are in the regions. There are some differences in the infrastructure and the style of health management by each of the different communities. And very important for Spain. We were getting out of the terrible economic crisis that we had 10 years ago. And for that reason, there were, because of the austerity measures that we suffered, the infrastructures were a bit weak in some sense. Okay, because we had to decrease a lot our public deficit, and therefore we needed to cut lots of health expenditures. And for that reason, we were on a huge problem in our system. Now, this is in this table you see some general characteristics of the Spanish population, but I don't want to waste time on that. But this is a bit more important because in this table you see that each of the different regions have these differences in the infrastructure, and this is particularly important in the case of the intensive care unit beds at different hospitals. So you see that in different regions, it is I don't know whether you can see, but in this column of the ICU beds, you see that this number is different for each region. So some regions have more ICU beds than others, and that's a problem when you have a pandemic of this style, in which basically you need this type of infrastructure, and actually this type of patients are in the hospital. I mean, their stays at the inpatient stays at the hospitals are very long. And when you have this type of constraint, this type of capacity constraint, that is a huge problem. Obviously, the differences in the infrastructure depends on many things. For example, in the level of GDP per capita in the different regions, which is different. The density of the population, because some are basically urban, like Madrid, for example, is an urban community with more than 6 million people. Or also the tradition in the management of the health system. So there are differences, but it's fine that there are differences between the regions. Problem is not whether we are different, but how we use whatever we have. This is the data on the pandemic. We can say that information on all the data during this pandemic has been quite transparent, although many times has also been a bit confusing, because there were several times in which we changed the way in which we were dealing with data. For example, with the disease, sometimes we were taking into account only those with PCR, the test PCR that had been confirmed. And they have died because of the virus. Sometimes they were adding some more deaths that shouldn't be there after, if you look at other statistics. So there was some confusion in the way we were dealing with the data, but actually it was quite transparent. And as I was saying, there was this complete lockdown, the state of alarm in March 15th, and then everything was centralized. All the health decisions were centralized at the ministry level. And in April, we had change starting in April 1st, the lockdown was only for basically for non-essential activities. So the economic world was starting to work a bit, but only a bit. And then starting in April 15 and then May 1st, we started to have some phase out stages for the lockdown. And most of the regions were still with mobility restrictions until the end of June. For example, in Madrid, which was one of the regions in which we had the highest problem with the pandemic, we were at home basically until the end of June. So from mid-March until the end of June without going to work, but basically with in the distance. These are the numbers of the pandemic. You can see here how the different regions, this is for the 17 regions and the 2 autonomous cities in Spain, how basically this is in blue, you can see the dotted line where we had the first lockdown, the complete lockdown of all activity, still with a few cases, still with a few deaths, about 200 in the whole Spain, but it was increasing very quickly, all the numbers of the infected population, and we didn't have at the beginning lots of tests, so we had also the problem of the tests. And after the measures were taken with the lockdown, and then only with the lockdown for non-essential activities, and then in the phases, we were controlling the pandemic. Actually, we can say that even if we started a bit late with some delay. With this type of measures of the lockdown, we can say that it was working at the end, and we could control in a few weeks, well, in a couple of months, basically, we controlled the number of deaths in our territory. You can see here in this other table, in this other figure that I would like to show you, how the fatality rates were changing from every 2 weeks in time during this pandemic. And by the end, basically, by the beginning of June, everything was getting much better, and the rate of fatality was decreasing a lot. But the month of April was terrible, with close to 1,000 deaths per day in the country, which was really terrible for for many families, for all the affected, and and for the economic, for sure. Who was affected? Well, basically the elderly. I'm gonna spend more time in that, but we had a terrible problem, specifically in the nursing homes, and many AIDS population were dying because of this virus in the nursing homes. So that was a terrible situation. Restrictions to mobility were huge. Here you can see how effective they were. And this is again where we started the lockdown, and this is how the measure in the level of 100. You see basically the level of mobility in February before the lockdown, and then you can see how in March, April, and June everything was completely quiet in Spain, and then we start to increase again our mobility. So basically this is also important, because you can see how this is where we started to have in March. Basically, in the below part of this figure, you see the intensity of the measures that we were implementing. So we were increasing this measures, the lockdown, all the constraints that we were having for the population, and at the same time we were decreasing the number of infected population. So actually we can say that these constraints to the mobility were actually working. And also, we increased the capacity constraint that we had, because we were adding some more beds to our hospitals. So there was a huge change in our hospitals and in new hospitals that we were adding in just weeks. So we were construing, we were basically building some new hospitals, mobility hospitals, for this situation, and in some regions up to 40% increase in the number of beds in hospitals. So that was very important, also something that we did. So in terms of resources, at the beginning it was terrible, because we didn't have enough tests, we didn't have masks, and we didn't have personal protective equipment. So that was a very difficult situation for our system. That was a huge market failure, not only at the national level in Spain, but also at the international and the European level, because the markets didn't work at all at the beginning of the pandemic. And that's something that we all should think about. And the direct impact of this was that we also had a high number, much more than in other countries, health personnel infected by the coronavirus. Then the mentioned problem that I already told you about the nursing homes, which was huge in the case of Spain, much more than other countries. And then we can anticipate that we had some problems. We could see that we had some weak infrastructures for our national health system. For example, in terms of the number of ICU beds, okay, which were not enough for this type of pandemic, at least. After the collapse, we had the construction of provisional hospitals, as I told you. Very important in the case of Madrid, up to 5,000 patients could go to this mobility hospital that we did in just a couple of weeks. We only used something like 1,500 beds in that hospital, but it was ready for that, and it will be ready now in case we need it. And in Barcelona, up to 1,200 beds also in a mobility hospital. Those were the more important ones. So we increase the capacity constraint, so we improve a bit more in that. And then also the other effect, indirect effect of the coronavirus, is that we didn't do some other health service provision that we used to do, that normally we do. So for other patients, for other chronic conditions, we were reducing the number of services, and that was affecting the quality of life of our other patients. That's also something that we need to take care about. In economic terms, well, the GDP, well, it's been a disaster. From April to June, the economic activity fall by almost 20%, 18.5. We still don't know how much is going to fall the GDP in Spain for this 2020. It seems like it's going to be something like 12.5%, which is a terrible situation for us. Also because we were getting out of the other crisis. And in terms of employment, for example, let me tell you just a few numbers. We were, maybe 13% of unemployment rate for you is huge in other countries, but in the case of Spain, we were coming from 27% 10 years ago, and now we were on the right track to have something like 13%. So it was improving, and only in a few quarters you can see how again this number has increased. Now we are in 16% of unemployment, plus something like 700,000 people who are now with the work suspended, and they are not in the statistics for unemployment. So this could be even more, much more critical number. To conclude, because I know that I'm taking a bit more of my time, a huge impact of the pandemic in terms of deaths, in human lives, but also in economic losses. Our national health system, basically, we have known that we have some lack of resources. Specifically, I think we should focus much more in public health and prevention, and try to combine all our resources together in order to be more efficient in the way we organize all our resources. Still, we had a very great recovery after a really bad start, but basically we can say that all the mobility restrictions worked. And for the discussion, and we will talk about this later, we would like to maybe know what we have learned and what's going to happen in this second wave. So thank you very much for your attention. I'm sorry if I took maybe a few minutes more than I...
Okay, thank you, Manuel. So yeah, I ask all the presenters to really try and keep it to the 10 minutes. And also for those who are participating in the seminar by means of attendance, please interact as much as you can to these presentations, and by means of contributing to the chat, and Ima will collect the questions. So now we have Dr. Tirinki, who's going to present the Finnish case. She's a senior specialist from the Finnish Institute for Health and Welfare. Anna, it's a pleasure to have you with us. Please take it away.
Thank you, Francesco. Can you hear my voice and see my slides?
Absolutely.
Good.
We can see you. The slide is very good.
That's great. So thank you. I'm very honored to participate this seminar, and I hope everything is fine with all the audience all over the world. So my name is Hanna Tirinki, and I come from Finland, from Finnish Institute for Health and Welfare. And the institute is a government agency with a mandate to support and monitor developments in health and social sector, as well as carry out research. And THL is also closely monitoring the development of COVID-19 epidemic in Finland. And in this, my presentation, I will address of our previous study, COVID-19 in Finland, preliminary analysis of health system response and economic consequences, what was published in Health Policy and Technology earlier. Our research team behind this study was from different fields, from social science, from health system research, and we have also a specialist of public law, and of course economic and financing specialist. And this study provides early analysis of outcomes of health policy measures, social and health system capacity, as well as economic challenges that has faced in COVID-19 pandemic in Finland. So few words of Finnish health and social service system. Health and social service, as well as most other welfare services, including schools, libraries, and daycare, are based on public funding and provision, mainly through the high decentralized responsibility of the mostly small municipalities of the median size around 6,000 inhabitants. So in Finland, we have very many small municipalities. And like in other countries in Europe, the aging population is a significant factor, and of course has been taking account when restrictive measures and lockdowns has targeted to population and to health system during this pandemic. And in addition, when we are making together conclusions of COVID-19 strategies between different countries, they need to record the different viewpoints. For example, realize that Finland is much more sparsely populated country than countries in the middle of or south part of Europe. First, I will tell you shortly what was learned out in our study, and secondly, I will have a quick look situation where we are going now with COVID-19 in Finland. And as we know, the situation is changing daily all over the Europe. And at last, I will make like a sophistical quest where Finns may succeed. What could be behind compared to low numbers of cases just now? Well, in this study, the aim was to explore COVID-19 pandemic impacts to health policy, to social and health system, to economic and financing system. And the aim was create an early analysis to find out ways to prevent, treat, contain and monitoring the virus in Finland. The purpose, we collected administrative documents on ministries and social health and economic authorities. And the collection took place to April to August in 2020, and it included most recent documents, reports, plans, daily news, and all available data related to COVID-19. And our analysis focused on government implementation to prevent COVID-19 from the viewpoints of health system capacity, prevention of the spread of the virus, and means of coping with the economic challenges. Well, some words of main findings of COVID-19 in Finland. Coronavirus strategy has so far been successful in Finland, and the impact of it has not been as extensive and massive than in many other countries. And of course, we still agree with this finding. The success may have been a result of combination of measures to tackle the outbreak, but there is also a kind of good luck, and we still agree also with this. And the good luck, I mean that the epidemic landed in Finland late compared to many other countries, which provided to the authorities and politicians a little bit extra time to learn from the experiences from other countries. And it seems that the restrictive measures were put in place early enough, and the instructions on, for example, physical distancing have been obeyed well. And the local actions by municipalities, hospital districts, and regional offices of central government have also been effective. And available information supports that conclusion that the economic consequences could be drastic in Finland, albeit less dramatic than in large industrial countries. And next I will present some digital tools that has implemented during the pandemic. First, one very important digital self-assessment tool has been Omaolo. Omaolo means like your own feeling, and it has played an important role to providing people and also prevented unnecessary visits to healthcare. And it's used nationwide in Finland, and it's available in Finnish, English, and Swedish. So maybe if you're interested, you can see from our website more in English about Omaolo self-assessment tool. But in practice, if a person suspects they have a COVID-19 infection, person is advised to make a COVID-19 symptom assessment using the Omaolo in websites. And if a person is deemed according to their symptoms as potentially having COVID-19 infection, they are advised to contact their own healthcare center. And of course, you can use that anonymously. And now over 500,000 questionnaires have been assessed since March 2020. The second health technology key documentation is koronavilkku, that means like corona sign. It has implemented after our article was published, and it's contact tracing app produced by THL. And the purpose of the application is to share the information of diagnosed COVID-19 anonymously with those persons that has been in a close contact with the diagnosed person. And at the moment, over 2.5 million Finns has downloaded the application. So our total population is 5.1 million. So half of our population has downloaded this application. But of course, it's too early to make conclusions of the long distance effectiveness. But at least now the experiences has been positive of that kind of application. A few words of contact tracing. THL has also collected and educated in a cooperation with universities, a pool of voluntary trackers who can be used to coordinate resources in case areas in Finland lack tracing capacity. And the education is possible to study online, and as the figure shows from Blue Line, more than 4,000 volunteers has educated so far. And some words also related to testing. Testing and tracing has been, of course, important element of the Finnish strategy all along the way. And we are still living with the hybrid strategy, when the strategy focus on testing, tracing, isolating, and treating, as you know. And our testing capacity has, it was about 13 samples per day on August, but it's still increasing. And now the capacity is about 20,000 tests per day, and all the capacity is not used. So where we are going just now, well, in Finland today, total cases is a little bit over 17,000 cases, and only, or may I say only, or well, every deaths are too much, but we have reported 361 deaths in all in Finland. And on September, the Ministry of Social Affairs and Health published an action plan with objectives to prevent the spread of the virus in Finland and to safeguard the resources capacity in healthcare system and to protect people, especially those in risk groups. And action plan divides the epidemic in the 3 stages: base level, acceleration stage, and spreading stage. And today in Finland, COVID-19 situation is in the accelerate stage in 7 hospital district area. You can see the red areas. And of course, that kind of analysis, real-time analysis, helps to evaluate the need for recommendation and restriction and their targeting in different areas. Well, where have Finns succeed? It's too early to say, but the overall resilience of Finnish society has been comparatively high, even though the COVID-19 pandemic will have far-reaching system effects on the entire society. Local restrictions, including consistent leadership and management of the problem, has been effective to cut infection chains. And already could be said that contact tracing until now has been successful, and also known that in Finland only a fraction of COVID-19 cases has been in healthcare workers. And after initial difficulties in spring, we have succeeded pretty well in distributing PPEs and guiding their use. So we had the same kind of problems that Manuel told us earlier with the Spanish situation with the PPEs. At the end, I can state that Finns has followed all the instructions very carefully with the social distancing, and actually keeping it in daily living. It's more like a rule than acceptation. So that was the situation in Finland. Thank you.
Wonderful presentation. Thank you very much, Anna. I would like now to invite immediately Marcello to present.
Can you hear me?
Yes.
Okay. So thank you, first of all, for inviting me in this very interesting webinar. And I'm going to give a brief overview of the COVID-19 experience in Italy and describe briefly the major interventions implemented by the Italian government to handle the pandemic. So let's start remembering that Italy was the first Western country to experience the COVID-19 emergency, and that the magnitude of the pandemic underlying all the deficiencies of the regional healthcare system. In particular, it required a huge injection of resources for the reorganization of hospital infrastructure, recruitment of health personnel, and supply of equipment. Another key, let's say, point of the Italian experience is that during the first wave, the virus was particularly severe in the northern regions, while mild in southern and moderate in the center one. However, in this second wave that we are facing now, these regional differences seems to be more homogeneous throughout the country. As Manuel presented before for the Spain, it's really important to describe the Italian healthcare system really briefly, because also in Italy we have a national healthcare system that is really decentralized. So the provision and the financing of the healthcare services are, let's say, on top of the region. So each region has its own healthcare system with its own model of financing and provision, and that in this COVID-19 emergency led to a really difficult situation, especially for some regions. So the huge range, the broad range of models, particularly in Lombardy, that was the most affected region, create really significant difficulties for the regional authorities to cope and to, let's say, handle the increase in the hospitalization, and particularly in the ICU. And as Manuel said before for Spain, also in Italy, the regional healthcare system suffered from financial cut to the budget over the last 20 years. So let's now analyze the COVID-19 trend. And here I pose a provocative question: if we are back to square one, so where we are in March, considering what we are facing now. So as you can see in the table, I reported the daily number of contagion, the daily recovered, and the daily fatalities in Italy since February until now. And it's easy to see that during the first wave that goes from February to May, the epicenter was the northern region here in panel B, while now in the second phase, as I told you before, this regional difference is still occurring, but is for sure less relevant than before. So the virus is now really spread all over the country. According to the first wave, the peak of cases occurred on the 21st March. And you can see that as soon as the number of contagion increased, there was the imposition of partial and then national lockdown. But you can see that now in this second wave that we are facing, the number of contagion is much more higher than the emergency situation that we were facing in March. An interesting point here to observe is that the number of fatality is not increasing as much as the number of contagion. And this, of course, must be due to the age of the people, of the positive cases, considering that from February to the end of May, the median age of the positive case was 55 years old, while in the last 8 weeks, the positive cases have a median age of 40 years old. So this for sure can contribute to the number of hospitalization and the number of fatalities. So let's now analyze the government response. I reported here a timeline with the major containment measures, and as you can see, I've also reported the seasons, as the seasonality factor seems to cover a really important role in the effectiveness of the policy to contain the spread of the virus. The response of the Italian government has been quite reactive, as you can see here. I labeled all the intervention like according to severity metrics, let's say from minimal to significant, the red one. So as you can see, as I was saying before, the response of the Italian government has been quite reactive as soon as the first case and the outbreak were identified on the 22nd of February in Lombardy and Veneto. However, the targeted lockdown that were targeted just to these hotspot or red areas, they were defined red areas at the time, were not able to stop the spread of the virus in the rest of the country and in the closer regions. Probably the virus was already there, but of course, the measures were not able to stop. So it led the government to impose harsher measure, implementing the decree Io Resto a Casa on the 9th of March, that imposed a national lockdown. And then like the continuous increase of the cases led the government to implement an even harsher measure, that is the Chiudi Italia decree, as you can see here, that imposed the shutdown of all non-essential economic activities, sorry. So with the decrease of the cases during the spring, at the end of the winter, let's say, and also the decrease in the pressure of hospital facilities, the government planned the exit phase, as you can see here, at the end of April. And the exit phase was planned in 3 main steps until the 3rd of June, where then all the restrictions were lifted. So during the summer, you can see that there were no restrictions actually in the Italian strategy until the 18th of August, in which the government imposed the closures of discos and nightclubs and imposed the mandatory wearing of masks because the number of cases were increasing, but still not as much to implement a harsher measure. So after exactly 1 month, 1 month and a week, harsher measures indeed were introduced to respond to the second wave that we are facing now, until Tuesday, in which the decree 4th November has been signed by the Prime Minister and entered in place today, actually. And basically this decree implements a differentiated lockdown, as you can see here. So with the new decree, the regions are classified in 3 risk areas: yellow, orange, and red, as you can see in the picture that I reported here. And the different areas will be, of course, subjected to a different level of restrictions. For example, the red areas will implement the complete shutdown of economic activities, and also they will stop any movement in and out from the regions and also the municipality of residents. While, for example, the yellow areas, so the areas with lowest risk, will just introduce a curfew from 10 p.m. to 5 a.m. And will shut down the businesses and the economic activities from 6 p.m. After the morning of the day after. So the risk of each region will be assessed by the Ministry of Health with the scientific committee on 21 parameters, based on 21 parameters. And this is a really novelty for the Italian response strategy because until the 15th of October, when the Ministry of Health published the emergency plan to face the COVID-19 emergency during autumn and winter season, we didn't have a national plan. So it was not clear how the government took the intervention and why some interventions were taken and some other not. As you can see, among these 21 parameters, the number of hospitalization and the occupation of beds with the current availability of beds takes a really important role. And indeed, you can see, I reported here, you can see that as soon as the number of hospitalization increase and the ICU bed occupation increase, harsher measures are implemented. So you can see in the first wave the national lockdown here, and then now the decree for November that I just explained to you. Why as soon as the number of hospitalization decreased, the exit phase was planned in the first wave. So let's see what happens in the next one. The government intervention for the hospitalization has been really crucial because, as you can see in the panel on the left, many regions, or most of the region, would not have been able to cope with the increased demand of hospital beds and ICU beds without the intervention of the government that increased the capacity of triage of the regional healthcare system. So the blue area is the initial capacity, and the red area is the new capacity, and I reported the saturation rate. So you can see, for example, for Lombardy, that even with the new capacity of ICU bed, the ICU saturation was really close to 100%. Despite this worrisome trend and the target set by the government to have at least 14 ICU beds per 100,000 inhabitants, you can see in the panel on the right that I reported that just 5 regions actually are meeting this target, while all the others are still below that threshold. And you can see here that the number of hospitalizations are increasing, and also the ICU demand. So to conclude, and I repeat the question, but anyway, let's see these key points that I reported here. During the summer, Italy was considered a model for other countries, so a model at international level. But the new spike of cases and hospitalization show the inability of the institution or the governments to control the virus. Particularly, this can be due to the technological intervention that are still not able, as the Finnish case presented really well before, to maintain, to control the virus and maintain the business as usual, for example, as in other countries, as I said, occurred. And also, just to mention also the economic dimension, despite the very important and significant financial intervention, the government is facing a really huge problem to maintain or to keep the small and medium enterprises alive in this economic landscape. So I conclude posing again this provocative question: if we are back to square one and we have to start again from the beginning, all what we passed through.
Thank you very much, Marcello. We are starting seeing some questions coming up. I would like to invite now Jonathan to present on Norway. And please continue on the chat, interacting. Ayman will collect the questions, and we'll try to address as many as we can. Thank you, Jonathan.
Thanks very much. Can you see the screen now, the slides?
Absolutely, yeah, wonderful.
Great. So I wanted to first recognize Coral Ocean and Ingun Schessel, who are my colleagues from Nord University, who produced this article with me. In the interest of time, I'm not going to go into huge detail. I'm going to make some broad generalizations, but happy to answer in more detail in the questions. So one of the first questions is, why is Norway interesting? And why may it suggest some different things from the other countries, even the other Nordic countries? It's a small country like Finland. It's just over 5 million in population, and that's very dispersed. There are urban centers, and the pattern of the pandemic in the urban centers is quite different from the rural areas. It's a wealthy country, but it has high taxes, but it is really wealthy and has high life expectancy. And that has implications too for the capacity of the health system to respond, and also the individual resources that allow people to manage the opportunities to stay well. It's the 7th largest oil exporter in the world, and the Sovereign Wealth Fund has more than $1 trillion. It owns between 1.4 and 1.5% of all listed company shares globally. It's huge, and I'm going to come back to this point. It's a Nordic country, and that means, like Spain or Italy or Finland, it has a national health service. It also has very high levels of trust in the state, and that leads to significant compliance in relation to state regulation. There's also a pattern within the Nordic countries of policy transfer, particularly from Sweden towards the other countries. And part of the consequences of COVID, I'm going to suggest, are a challenge to the existing patterns of Nordic relationships. The peak deaths in April, I should say that overall, there have only been 284 deaths of COVID and only 22,953 cases. So there are very small numbers of COVID cases in the country, despite it being a small country. Peak deaths happened in the 6th of April. It was among the older population, more men than women, though in the 90 plus, because of demographic shift, there are many more women who are 90 plus that age different, that gender split didn't stay the same. The cities are the hotspots, and this is particularly the case of Oslo and Bergen, and we see that's still the case coming into the second wave. The capital had by far the highest infection rate, and what we saw is particular hotspots around immigrant communities, and this led to a response in policy that I'll touch on in a minute. There were a series of policy and technology responses. Some of them were about stemming the spread of the virus, so travel restrictions, closing national borders, social distancing and closure of restaurants, cafes, and bars. Schools were closed. And also the increase in capacity of ICU beds and a national coordination. So despite the fact that there are regional health authorities, there was national coordination of both PPE and pharmaceutical provision. And on the whole, that worked quite well. The impact on the economy also was something that quite early on was something the government took care of. The work furlough scheme and a reduction in the cost of redundancy. So companies only had to give 2 days notice, and also the cost that they bore for redundancy was much lower. There were loan guarantees for businesses, and these were targeted particularly at aviation, construction, and seasonal businesses, tourist trade. And it led to, for instance, the government buying up some of the air routes and nationalizing some of the train lines. There was a subsidy to rehire those workers who'd been laid off, and there's been increased funding for education. So different kinds of investment which were seen to mitigate both the immediate and the longer term consequences of the impact on the economy. There were also something about social costs. There was support for immigrant qualifications and getting into employment. So one of the responses to seeing those hotspots surrounding the immigrant communities, particularly in Oslo, was a recognition that both communication and provision for these communities was insufficient. Kindergartens were reopened early, and the schools were partially reopened and then fully reopened also early. And these were framed as mechanisms to strengthen social integration, to respond to what had been the perceived mental health consequences, but also the social consequences of the pandemic. Within that framing of addressing social costs, the support for unemployment and the furlough scheme were framed. So where you sit and which ministry you're in frames whether or not you see this as mitigating a financial impact or an economic impact or strengthening social integration. Well, what's happened since? So we clearly see a rise, a creation of a second wave. And these are data from a couple of weeks ago now, but we can see that second wave happening. But again, as has already been suggested, this second wave doesn't seem to generate nearly as many hospital admissions or deaths. One of the policy responses also apparent in the second wave is much more opportunity for local regulation. So for instance, in Oslo, the municipality has much more, not draconian, but the much more strict regulations around mask wearing, social distancing, and closures of retail outlets. The other change, again, learning from the first wave, is that now care homes are required to provide opportunities and support for older people to have social contact. Again, responding to what was seen as the negative social consequences in the early phases. And there's much more holistic support for vulnerable children. This again was one of the learning from the first wave. You saw vulnerable children, children in violent households, for instance, who lost all their support because it was accessed via the schools. So this has been put in place much more strongly. The new and tighter restrictions in response to the second wave were actually announced yesterday by the government. So we'll see how they actually take place overall. So the learning has been around this need to be more sensitive to minority and immigrant health, to think about that in terms of vulnerable children. And also, I think, or we think, that there has been some fracture to what has been typical patterns of policy transfer and indeed orientations to Sweden. It was really notable that the border was closed over the summer to Sweden. This is not something that has ever happened before. And maybe this is also about a policy window, an opportunity to reorientate the economy. It's the first cut in oil production in 18 years has been announced. The chief executive of the Norwegian Central Bank talked about moving from an oil-dependent nation to an oil fund nation. So perhaps just as the pandemic has created a challenge to the policy and in some, a particular challenge which has been mitigated by the Sovereign Wealth Fund, by the wealth that has been collected from the oil industry over the years. It also is leading to a shift in priorities, priorities in health towards immigrant populations, to vulnerable children, to differential care and support for older people, but also perhaps for a reorientation, a different economy that will emerge. And that's one of the reasons I think Norway is a really interesting country to look at. Thank you very much.
Thank you very much, Jonathan. Very insightful. And I welcome now Matthias for the Swedish case and perspective. Thank you, Matthias. Take it away.
Can you hear me? Good.
Absolutely, loud and clear, and we can see the slides.
Perfect. So similar to what Hannah spoke to, we gathered a group with some different backgrounds, both from infectious disease epidemiology, but we also added experts in cultural understanding, because there were definitely issues about cultural communication, which was important in the Swedish context. I took this slide to show from the US, and I think sometimes the world's perspective about Sweden, that we don't quite get it right about Sweden, that people think we're treated like a fake crisis. We have not. We have been taken quite serious. And people who say they want to be like Sweden, they don't understand that we have been quite restrictive as well, even though we haven't done a formal lockdown. So we need to get the perspectives right about this. So to put a little bit in context of this, so this is numbers as of to date, and the blue line here is roughly when we made the publication. And I want to highlight a few things. Well, first of all, we basically went into lockdown. So people who say they want to be like Sweden, we had quite a restricted time during the early phase of the pandemic, and people were working from home. You could go in the subway, it was basically empty. So it was quite drastic. What is important is that we had a very high peak of disease and mortality, and Stockholm was, with 2 million inhabitants, were really hit very hard, and it had a relationship with the sport break from school in end of February, where a lot of people were out traveling. So that led to a lot of initial peak here. What is important is that the same policy led to an 80% less mortality in another big city called Malmö in the south of Sweden. So we have to look at the nuances of this. And when we look at it, we've been able to handle the ICU capacity all along. So it's been working quite okay. And as you see here, this is the ICU level here. It's starting to go up a little bit. Mortality, which is down here, it is still rather low. And so even though there was even though it's spiking now here with number of infected, it is still not that high. And the reason why I say it's not that high compared to before is that during the early season here, up until May, we didn't really have testing capacity. So the testing here suggested that there should have been about 40,000 people infected by end of May. But based on the modeling and different things, it was probably 20 times more that were infected at that time. So maybe it was 800,000 to 1 million. So compared to the numbers here, this peak that we see coming now is not that high. They're saying that maybe it's 10%, 10 to 15% of what happened during the spring. So we are in a better position. And what's been said many times, this is a marathon, not the sprint. To talk a little bit about the Swedish organization of healthcare, what is important is that we have, similar to what was mentioned about Italy, is that we have a very regionalized healthcare, where some of the healthcare is provided by the 21 regions. However, the elderly care is provided by the 290 municipalities, and they are independent governed. So it is very regionalized healthcare. And when we talk about the summary of what we thought was important from our policy review, is that it was very much a close collaboration between government and society. There was no forced lockdown. It was rather soft measures. And it's been suggested at that time that it may be a model to learn from. We did manage to flatten the curve. Where we really did have a problem is that we weren't really able to provide the right measures in the elderly homes. I'm going to come back to that. People sometimes think that Sweden didn't do so much. Here is a summary of the different activities we have done, and we categorize them in 4 categories: managing the curve, protection of the old and vulnerable, healthcare capacity, and sustaining the economy. And similar to what was explained from Norway, there was good protection for the economic consequences in society. And there's been a lot of efforts to manage the curve, even though in a different way. One of the things that have been different is that schools have been open during the whole pandemic. However, universities has been run on a distance. So there's a lot of activities that has been done to manage the situation. What I would say is that the core of the Swedish effort has been the ability to build trust in the simple basic measures. And this is the head of the person responsible at the Public Health Institute, Anders Tegnell. They would have daily briefings during the most intense period, explaining what was going on. And they were able to bring a lot of trust into society for the actions they were taking. And that has been very important, so that when they say, now we need to be more careful, like what is happening right now, people are responding. So with voluntary measures and trust, they've been able to maintain a good functioning way of reducing the infections. What is important here, this is from the World Values Survey, and if you look here in the upper right corner, Sweden is an extreme country on one end, but we have a lot of migrants from another perspective, and this has been one of the issues in the Swedish context, that as Swedes we would tend to be rather rational. We listen to the scientists, but if you come from another context, the Middle East, for example, you don't really trust your government, and you're not used to listening to scientists the same way. So when the Swedish public health talks, it wasn't really heard in the beginning by some of these migrant groups, and this was one of the failures in the Swedish perspective. What we did here is to discuss different perspectives of how we assess the COVID policy successfulness, because I think we need to look at it in different dimensions. The first question, which I think is crucial, is you have to look at the broader population who's not at risk, and how measures influence economy, well-being, and other aspects of health. And here we have done, I would say, rather well in Sweden, and I think this has been one of the drivers. When it comes to what we call the shielders, I don't think we have done so well, actually. We haven't really targeted the measures there in the right way, so that led to people getting infected. And where we really have failed is among the old and the vulnerable. And like was said from others, it was in elderly homes, and we have quite a broad variety on the quality of elderly care. In some elderly cares, there was no issue. I think importantly, it was clear leadership. It was working rather well. In other elderly homes, there was an issue of people weren't really heard, and they didn't know what to do with the information. They didn't have good hygiene in place. So that was an issue. And here, this is a follow-up of elderly care and hygiene, and both in hospital and in elderly care. And you see here on the left side that in hospital, we have very good hygiene routines, whereas in elderly care, it's about 60% that comply to the complete guidelines. And I think this is an important issue, and this is something you can't really fix in a short period of time. Coming back to this with the difference in different regions. So here, if we look at the mortality per 100,000, you can see that Stockholm, compared to the region of Skåne, is 5 times higher than the same region, with compared to this region. And I just updated the numbers here on mortality today, and it's rather consistent. So it's a rather complex question to understand the policy. What is it that's right and what's wrong? So the same policy which has been seen as rather loose in Sweden, in one region here of Skåne, it leads to very low mortality, I would say. So we need to be humble to understand the complexity of the issue. And just to mention a few things about this with mortality, there are some studies going on in Sweden where they looked at, are you dying from or dying with COVID? And they are suggesting that it's not always that you die, you may have COVID, but it may not be the reason why you're dying. So maybe you have another reason of dying while you also had COVID. So I think that's an important question. Another study that came out was based out of Stockholm, where they looked at the cause of death from people dying from COVID and the ones dying from other causes. And as you can see here, the people dying from other causes were actually younger than the ones dying from COVID. And it helps us to give perspective of what we're talking about. What is important, this is another study that came out here looking at different factors influencing mortality. And I think the key issue here is, if you're a man from the Middle East living in Stockholm, that's a high risk combination. So there are many things influencing the differences here. So that was my takeaway from a few highlights from the Swedish perspective.
Thank you, Matthias. Much appreciated. And now I would like to welcome Professor Fordham. Richard, are you there? Richard? I see Richard online. Okay, there may be some issues with Richard's connection, perhaps. So I'll go, while we wait for him to return, I'll go to Zach, the song to present a multi-country paper. Zach.
Can you hear me and see my screen?
Yes, I can see you and I can hear you. Thank you, Zach. Take it away.
Okay. Hi, everyone. It's happy to be back at MCI, even as in digital form. I have actually recently graduated from the EU HEM program, and myself, along with Emmy, who's a colleague of yours, Dr. Peter McMeekin and Dr. Mehdi Ami, did a bit of a comparative analysis between France, Belgium, and Canada. So a little bit of a change of pace, but it addresses some of the issues that we've been talking about in terms of decentralization. So the comparison between these countries, what we really focused on was the healthcare competency. So in Canada, for example, the healthcare is almost exclusively managed by the provinces and the provincial governments, and the federal government or the central government only has a very small role to play. And in the middle, we have Belgium, who has a bit of a mixed competency approach. So the provinces have some autonomy in terms of public health, where the central government really takes control of healthcare administration. Whereas in France, we have almost completely centralized administration of healthcare. So when it came to the COVID pandemic, we could see that these different governance systems really had an impact on the way that the pandemic was managed and the responses that we saw. Just a little bit of an overview, because some of this stuff really makes a difference as well. Canada, Belgium, and France have significantly different populations, but more importantly, different population densities. So in Canada, for example, it's substantially larger in terms of area, and a lot of the rural areas have almost no people per square kilometer and are really concentrated in the urban centers. Whereas in Belgium, there's really no escape from the urban density. And some of that's going to come into play when COVID cases start to arise in these countries. Otherwise, these countries become a really good comparison because the percentage of elderly populations, the prevalence of chronic diseases, and things like smoking rates, which are other risk factors for COVID, are all very similar. So what ended up happening with COVID in these countries? As you can see from the graph here, the first wave, we saw really quite a high spike in cases in Belgium, in France, and in the Canadian province of Quebec. And the timing of the school holidays were in fact really important for when these spikes happened and how severe they were. So with Quebec and Belgium, their school holidays happened as the pandemic was really getting started, and people were going traveling and coming back and bringing a high number of cases into these areas. And France to a lesser extent, because their school holidays are a little bit more staggered. Whereas by comparison, the blue line here, which is British Columbia, another Canadian province, they had their school holidays quite a bit later, and they were able to put in place a bunch of measures before the holidays started. And as a result, they really didn't see the level of cases that were seen in the rest of the country. So what happened with the healthcare systems when these cases came through? Just a brief overview of the differences between the systems to start. The spending is roughly the same, but as you can see, Canada has quite a bit of a lower capacity in terms of physicians, in terms of hospital beds, in terms of ICU beds. And another key difference is the long-term care system, where in Canada, there's almost entirely private funding, not a lot of public access or public provision of long-term care. And that ended up becoming a really big issue within Canada, where long-term care residents were receiving substandard care and represented a really large proportion of the deaths from COVID. Whereas in France and Belgium, the problems were mitigated quite a lot by more effective public provision of care in the long-term sector. So in the end, the mortality rates overall generally followed the rates that we saw from the number of cases that we were seeing in these regions. Although Belgium had a very broad definition of COVID-19, you may have seen some fights with the tourism industry in Belgium at the beginning of the pandemic, where they felt that Belgium was counting the cases too high and that they thought it was going to scare people away from the region. But in fact, they still ended up with quite a high, even if you account for different factors and different measurements, they still ended up being really, really severely affected. One of the things that the healthcare system was able to do in Belgium and France, however, is because of a mix of centralized and regional responses, they were able to send patients from the most affected hospitals where the ICUs were really overrun to other regions that were less affected. So some of the more rural regions in France, they designed trains and sent patients over there with military escort. Whereas in Canada, this is not possible. The provinces are very isolated in terms of their healthcare competency, and there's almost no capacity that exists for them to work together. So in Quebec, the ICUs were being really hard hit, but there was no capacity in place, and the central government did not have the healthcare competency to arrange for something like a transfer of patients. So even Ontario, which is the black line, is a neighboring province of Quebec, and they were much less affected in terms of severe cases. But in the end, this decentralization kind of did not allow for a cooperation of sorts with the healthcare system. So how did these governance systems shape the policy directions? So the provinces proved largely agile in wielding their exclusive competency. So kind of what some of the other presentations have touched on, they were able to have a really local, regional focus to some of their travel bans, some of their messaging, and their testing strategies, with the central government only playing a supporting role. But then we also saw on the other side, little possibility for cooperation, and severe weaknesses were exposed in the long-term care sector and the ability for cooperation between provinces. In Belgium, there was quite an unclear division of responsibilities, and it led to delays in the response. Existing interregional tensions between the French, Dutch, German-speaking areas ended up causing political problems, and each of the regions started to blame each other for some of the problems. And in the end, it took a lot longer to establish clear competencies, and the response became scattered at the beginning, and in the end resulted in a much more severe result. In France, a little bit the opposite case of Canada. The decisive action that France was able to take, they could lock down quickly, organize patient transfers, as I discussed, and have a really robust data management system. However, they really were not able to delegate a lot of the competency to the regions, which in some cases could have led to more effective rapid testing, more targeted containment measures, and existing tensions between Paris and some of the other large urban centers were really inflamed by some of the, and they continue to be, by some of the decisions that are being made along the way. And that brings us to the ongoing situation. As we all know, the second wave is upon us in Europe, and the robust economic packages that were passed by the countries, they were enough to start a bit of a rebound in the economy through the summer. But as the new restrictions and lockdowns come in, as France France and Belgium both, in fact, have just started a full lockdown again for a month, it's really hard to say if that's going to set back the economy completely and require an entire new set of stimulus. All three of the countries have basically returned to the patterns seen in the first wave. The cases have spiked, and really what that shows is there's a low effort in contact tracing. It's been not have a lot of traction. And the apps, which all three countries developed to contact trace, really had low download rates, and it didn't work. It didn't work out in the end. So the commitments that were made, in the end, we may lose them in the second wave, but this is yet to be seen. So if you're interested, I know it's a lot of information. You can find our full paper in the COVID-19 special issue.
Wow, that's excellent presentation. Now, what's that? So thank you very much, Zach. Excellent presentation. Everybody, we are conscious we are running over time, but we feel that we want to stay and continue. So we have a great speaker coming next, Richard. So Richard, take it away, and then the panel with the various contribution from the panelists reflecting on their country, and of course in relation to the presentations and whatever they feel to contribute, and also dealing with some of the questions coming through. So dear Richard, the floor is yours.
Thank you. Thanks, Francesco. I hope you can, I'm going to try and share my screen, but I'm not sure that I can see the option for it. But if we go, I don't know if you, can you see?
It should be at the bottom in green, share screen.
Yeah, I've got that, but okay.
Yeah, it's starting sharing now.
Can you see lots?
Yeah, we've got
Do
you.
you see the
Slide
graphs?
on, yeah.
Okay. I don't know if this is an advantage or not, but I'm not going to give a PowerPoint presentation. You may or may not be pleased to hear, but I will give you some. I'm going to share with you some of these slides and what we've been doing. So I've been basically concentrating on looking at the pandemic from a local-ish point of view, from the southeast of it, or the east of England. I don't know if you can see my cursor. Does that show up as well? Yeah. Thank you. So we're in Norfolk, which is around that arrow there. And basically at the University of East Anglia, we've been working with the health system in bringing researchers and clinicians together and public health people to establish what the facts are locally, because we felt that there was a gap between the evidence and what people on the ground were actually hearing and needed to hear. So we formed this group that was really to support the people on the ground and the decision makers about the real facts that were impacting on our region. So in the context of that, I also want to obviously talk about the UK's perspective across the whole country. But just to say that Norfolk has a population of about 700,000. So, and we have one of the lowest densities of COVID outbreaks at the moment. As you can see from these graphs nationally, this is produced daily from the Department of Health. So this is directly coming from their feeding from their website. You can see how the cases, how things have moved on over time. And you can see that we were very bad at testing people at the beginning. We didn't have any not enough by far testing facilities. We've now got a lot of testing facilities, and of course the number of positives has risen accordingly. We measure deaths from COVID up to 28 days. So a lot of noise in that statistic, as someone has mentioned, do they die of or with COVID? And that came in halfway through the pandemic as a measure. And as you can see, it's now starting to rise again, but nowhere near the number of deaths that we had in the first wave around about March. Hospital admissions are the key factor in this whole set of indicators, and because it obviously reflects the severity of conditions. We're not seeing we're beginning to see, but we haven't so far seen the extent of the hospital admissions, which nearly, not quite, overwhelmed large parts of our healthcare system at the beginning in the first wave. Dipped right down over summer, and a very hot and nice summer, perhaps unusually for the UK. We had long periods of good weather, and then it's gone back into winter now, and we are beginning to see the second wave pick up. I'm told, well, there are parts of the country which have very high levels and almost full admission to their hospital capacity and ICU capacity. We're able to process a lot more tests because we've actually rolled out a lot more testing capacity. So this is the national picture. I'm just going to go to this map, and you can see the variation. You'll see the variation in COVID infections, hopefully in a second or two. Yeah, and I'm just going to scroll down a bit more. And we're here in November, but if we slide this bar back, sorry, so we grab hold of it. You can see the lighter colors obviously indicate less infections. If we go back to May, obviously we had a high level in May, March. It was pretty bad, but going forward, over the, as I say, over the summer, it tended to drop considerably, but now has gone quite nationally, as you can see, pretty bad across the whole country. Norfolk is Norfolk and the east of England are one of the areas where we're less impacted. It tends to be a regionalized outbreak at the moment, with mainly areas in the north of England suffering more than the south, but there has been pockets of outbreaks also in Wales and Northern Ireland, particularly around Belfast. So you can see that it's quite a mixed picture, which has different impacts on our healthcare system. So we've been meeting every week as a research group, trying to look at this. We've been comparing models that have been produced nationally and adapting them for our local situation. The model predictions have been very varied, and we were confused by why some of the models were predicting higher levels than we actually saw. And there's still quite a lot of controversy along those lines. We're now into our second lockdown. We went into second lockdown yesterday, which is less severe than the first lockdown, with people still able to go to school, children still able to go to school, people allowed to go to work if they need to go to the workplace, and students going to university with some restrictions. We've been paying a furloughing wage to people who've not been able to work at 66% of their normal wages, and we've also been giving quite generous grants to the self-employed and small businesses. We've had a period before the second lockdown now of a regional lockdown policy, which kind of was working but wasn't given long enough to work. And we've had that was a 3-tier system. So every part of the country was put into a tier. As you can imagine, the blue areas on the map in the north were given the highest tier, and they were very unhappy about that. and we're given some financial bailout to compensate them for their businesses, again, which caused quite a political furore in parts of the north like Manchester and Liverpool. However, we've gone back to a national lockdown now, so that's kind of evened out the pain, if you like, although now people are saying, and people with low levels, well, why should we have to put up with the levels of restrictions that people, when we've got a very low rate of COVID, in fact, quite low in some areas. Rates of admissions to hospitals have not been as bad this time round, although there is evidence, as you've seen, of it increasing again. Death rates particularly haven't been as high per 1,000 cases admitted. And this is an interesting one. We've talked to clinicians a lot about this, and there are certainly fewer patients going into ICU that have been admitted than there were in the first wave. We think that's partly an age thing, because there's many more younger people going in and being admitted with COVID than there was in the first wave. So, and then others, they don't tend to be severely affected. But it's also, we think that our ICU units are being more discriminating as to which cases they take. They were quite discriminating in the first wave because they weren't taking everybody, and didn't think your chances were very good. You probably weren't going to go to ICU. But in this way, it's more about, is it appropriate to put people on ventilation? There is quite a lot of argument and quite some good evidence that ventilation actually was harming some patients. It was doing more harm than good, and it wasn't the best thing to do to put everybody on assisted ventilation. So more about, it's now about, if they do have ventilation, it's more about CPAP, it's more about oxygen, but it's not about assisted ventilation, and that seems to be keeping the death rate, contributing to the low death rates in ICU as well. So that was an interesting. We're still doing badly though at testing. We were nowhere near ready when the first wave hit. We didn't, obviously, I don't think anybody was, but we couldn't roll out the extent of testing, let's say they could in Germany, because we just didn't have laboratories and the capacity to do that. We're now testing, the government tell us we're testing 500,000 people a day. There's maybe a little bit of an exaggeration in that, but we were testing less than 3,000 a day at the beginning. We're still limiting people to the pillar, what we call the pillar 1 test, which is basically those who've got some healthcare need or work themselves in the health system. So it's very healthcare focused testing. Whereas we're now beginning to offer it out to what we call pillar 2, which is basically the rest, the community. But we need to build, we are building more laboratories. We have built some more laboratories and so on. So we are not doing so well on testing nor tracing. We have a testing and trace app that people don't use. People don't seem to be very motivated by testing and tracing. They seem to be off-put by it. And the tracing service that the Public Health England uses is under strain. I don't think they've got the capacity to follow up cases in as much detail as they really need to in a contact tracing scenario. So I think they're struggling, but we do have contact tracing. The compliance with testing, if people test positive and they don't need to go to hospital, is still low. I mean, it's estimated that only 20% of people actually follow government advice and stay indoors and isolate 14 days. There's all sorts of behavioral economic reasons and behavioral psychological reasons for that, but it doesn't seem to be something that the English people like to well, I say that, I mean, I think they just find it difficult to do for various number of reasons in our situation. Schools have gone back, but we're not seeing any great increase in school outbreaks. The economic situation, I'll finish on this. The economic situation is really difficult. We were going back, we were seeing signs of recovery in the economy. The government has stimulated demand in a number of ways, including a £10 voucher for meals out on certain days of the week. But this second wave, the second lockdown has really stopped the economic recovery in its tracks. And a lot of businesses are now going out of business. and that, I mean, the recent announcement about carrying on the 60% furloughing may help toward that, but it's still a very tough scenario economically in this country. We're not as rich as Norway, and you know, we're trying to support people, but I don't know how long that can go on for. But meanwhile, we are very good at basic science, and there's 2 promising vaccines coming along, one at Oxford, one at Imperial College, being developed with drug companies, pharmaceutical companies, and I feel that there may be some optimism there that there will be perhaps a vaccine. I think they're talking about a vaccine before the end of the year being commercially viable. So it's not all doom and gloom, but certainly it's patchy, and we are still not out of the woods yet. Thank you.
Thank you, Richard. All right, so now I have the pleasure to introduce you to our panelist, Dr. Darren Flynn from Teesside, the UK, Dr. Shri, who is based at Innsbruck University, Andrew Matthews, who is based in Monash here in Australia. Thanks for being up so late, and also Finity. And Duan Lee, who's one of the guest editors based at University of Newcastle. So starting with Darren, we've heard a number of different case studies and perspectives. Clearly, there is a lot that has been probably that can be summarized as you know, a quite harmonious approach, if you like, to something so impactful in terms of progression and intensities of the measure you utilized. But you're based in the UK, so one of the most affected nations. Would you, and your background, of course, it's from psychology. So I would like to hear your views about the responses and whatever else you want to add on the countries that you've listened in today's presentation. Thank you, Darren.
Yeah, thanks, Francesco. Yeah, I mean, it was a fascinating overview, and you know, I learned a lot from the presentations. But what strikes me is a lot of similarities in terms of the mistakes that were made at the beginning. For example, in terms of the nursing homes, in terms of the technology not being in place to, in particular around test and trace, focusing specifically on issues of the local healthcare systems being overwhelmed, and the economic considerations then was dealt with after that point. But there's also the conditions that created a lot of these issues, which was austerity in a number of countries, because of the lack of investment in infrastructure such as public health, for example. I think when the onset of the pandemic occurred, that really took a while for countries to catch up and build that infrastructure because of austerity. And interesting as well around the shortages of PPE and different policies, and a lot of, if you remember saying, the UK dithering around the use of face masks and the effectiveness of that. And now we're clearly in the second wave, and I think some lessons have been learned. However, I think the biggest issue that we're facing in the UK is public adherence to the messages, which have been, we've had sort of a tiered system in place up until a second national lockdown started yesterday, and I think it's confused a lot of people. And thankfully, the deaths are not as high as the first wave, and there's the risk of the NHS being overwhelmed again. But I think one of the issues going forward, especially with the Christmas period coming up, is adherence to the lockdown restrictions. So I think that there's some work to be done on public health messaging and the clarity of that, and also clarity in terms of reporting, because we've had some difficulties in establishing precisely what is the data, and there's been changes in the way the data is being collected, in particular around death. So for me, I think it's all about having Also as well with England, UK having 3 devolved nations and having a coordinated response across the entire devolved nations is also an issue.
Thanks, Darren. Very good points. Surely, you are based in Jerusalem, and what's the situation, and what can you, what are your thoughts about the experiences on the countries that we've heard so far?
Okay, first of all, let me say thank you for great presentation. It was really insightful and very interesting. So for all the presenters, really thank you. I would like Francesco to make 2 points. First of all, I think her name was Pia Henkel questions refer to the decentralization and centralization management of the pandemic or the health systems. If I can share my screen with you, I brought some data about one of our successful, actually, management of the nursing home cares, the pandemic in the nursing home in Israel. Can you see my screen? Is it okay? Okay. So at the beginning of the pandemic in Israel, as all over the world, we didn't do a very good job in the nursing home or the long-term care facilities. And that was really came with a very massive public criticism. So around mid-April, the government appointed a very centralized management of the nursing home the COVID-19 in the nursing homes, and it was very, very centralized. Until today, they are working, and they have actually, if you can see here, they gathered a very established work plan, and they are working with a single headquarter to coordinate the government efforts dealing with the nursing homes. They expand the home front command's role of the Israeli army, and actually the home front command was very important also to help the authorities. And they had a very they have very steps that dealing with each of the nursing homes. For example, they allowed family members to visit, but they checked that the visits were in a special places in the nursing homes. And very recently, they now make the most efforts, and all of Israel actually, they put the most efforts on testing. And today they are around 10,000 to 15,000 daily samples of tests only in the long-term care facilities. So if you can look at the results, it's quite shocking. So Israel, we suffered 2 waves. So I don't know if it's wave or just. So we had the first lockdown here around March, and then we had just about a month ago another lockdown. And in the red line, you can see the all population COVID-19 deaths, and in the blue line, you can see the long-term care facilities COVID-19 deaths. And you can see that at around June, the COVID-19 deaths considered in the long-term care facilities considered to be around 60% of the total deaths. But now it's much less, and it's only about, I don't want to say only, but it's about a third of the deaths. And if you look on the growth rate, you can see while the all population growth rate it's increasing, the growth rate of the long-term care facilities is it's less than the total population, which I think it's amazing. It's amazing success. That might be answer. I don't know. Maybe that's what we need. I don't know. A very centralized management of this pandemics, especially in countries like us in the Middle East, that the trust in the public, in the decision makers, and in the government, it's not that so like as we heard before in the Norway and Sweden.
Thank you, Shirley. This is very interesting. In fact, Andrew himself had some considerations about this issue related to decentralization or centralization of the response. So, Andrew, would you like to step in at this time?
Sure. Thanks, Francesco. I really enjoyed the presentations. Thanks everyone for putting them together. I'm in Melbourne, Australia, so I suppose our numbers are a little bit lower than everyone else's, including Norway, but Melbourne was regarded as the COVID capital of Australia. So we had quite a run until recently. I think we had 6 days in a row of no cases, but it got up as high as 800 in a day. What stood out to me, 3 things I think you've mentioned. First of all, Francesco, the first one, nearly every presentation mentioned decentralized or local and centralized, and so this oscillation between when is it right to centralize something and when is it right to decentralize something is very interesting. And I think in Australia we also saw some states and regions centralized and some didn't, and there were different experiences. So I don't have an answer to that, but it's a really interesting theme. In nearly every presentation mentioned the word decentralized or centralized or local. So there's something in that, and what is the leadership to do that? The second thing I think I noticed is really around the ambiguity and clarity of what is the problem we are trying to solve here. And many countries seem to oscillate between, and politicians between, I'm trying to eliminate COVID, or am I trying to stimulate an economy, or am I trying to protect the healthcare system? So I think there's a step back to think about what is the it, and if we're not careful, we're in meetings and people are solving it, Francesco, and addressing it, and we're getting better at it, and we don't really know what it is. And I think, Matthias, one of your papers probably has the best first effort at a definition, at least, of having a clear goal. And it's not an easy thing to do. And the third thing, I don't know what the heading for this is, but the dynamic is kind of love and power. You know, how do you support a country socially, but equally, how do you have some enforcement or power to get things done? And I see that most of the talks were grappling between them. And so then my 3 things would be the sort of hub and node, or when do you centralize, decentralize? Second, how do we get clear about it? And there's a balance between ambiguity and clarity. And thirdly, I think there's a dynamic between the love for the looking after the social side and the power or enforcing things to make it happen. And then I can't help thinking about that question of, are these things that we're seeing now, they're new things because of COVID, or COVID has exposed cracks in our system and systems that were always there, but they're now much more visible. And so we're by necessity reacting to those. So I hate to say this, but it's probably not the worst pandemic that we could have or the world could have. So if this is a warning of other things that could happen, how do we move from reacting by necessity to being more ready in the future for such events?
Yeah, very good points.
Enough for me, Francesco.
Yeah, no, good. Well, we'll come back to these points. Clearly, the big elephant in the room is probably not looking at the problem like in the eye, right? Because everybody knows that the real most effective and efficient way to deal with this is with a clear global governance response with devolution of powers. But that is very far from being a reality.
I don't know that it is, Francesco. I think there's an oscillation between when do you centralize things and when do you decentralize them. And someone can do an academic paper on this, but left to their own devices, I'll call it hubs and nodes. Hubs are good. We should do more centralizing. So we humans get in the way and we centralize even more, and it's not the right thing to do. Left to their own devices, hubs kind of enter a system, grow, and then correct things. So we need them, but I don't think more is always better.
Yeah, no, interesting. Obviously, when it comes to defining the goal, and it's a good timing for Duan to step in, We've had several discussions, and we are in fact thinking about a paper or working actually on it, trying to look at what the implicit and explicit goals in fact are, and even there countries don't agree, even in the case of what they want to achieve with the pandemic. Duan, you of course are based in Australia, but have the luxury and privilege to be able to connect to experiences in Southeast Asia, where the technological effort has proven to be, as well as in Australia, in particular in New South Wales, extremely effective in the space of, for example, tracing, which is fundamentally basic technology, and it's been extremely effective. So both, I would like to hear your views on anything that you want to comment on, but especially on these two elements. Thank you, Duan.
Right. Thank you, Francesco. First of all, thank you for all the presenters. It was a great presentation, everyone. I learned a lot from what's happening in Europe. As Francesco mentioned, I'm in Australia, and I do have interest in Asia, so I had more focus on that. But I'll first start with the technology part. Obviously, in the first webinar, I presented what kind of technology really worked well in Asia in terms of doing contact tracing and what is needed to be able to be successful in those technologies. And like all countries around the world, like developed countries, they do have the capacity to bring in these apps. And the presenters today, they all mentioned about different types of technologies. Some countries were successful, some were still, the uptake was very bad. And it could be because of the cultural background of what people think about these kind of privacy intrusive apps. But also, I did mention that there is a fact of how well you believe the government would handle your data. So that could also be in the scope of centralization and decentralization. And then some people were saying that, like in Norway, the people would follow what the government, trust the government's direction, and will be more adhere to what kind of policies were put in place. So in those countries, maybe the apps worked a little bit well. And also, it doesn't necessarily mean that decentralized countries, it won't work, because if you look at Australia, in New South Wales, as the first wave was dealt with, and the recent few months, we've been doing very good contact tracing. And that was because the numbers were small. So we were looking at like 1 or 2, maybe less than a dozen people being confirmed each day. So with the lack, even with the lack of uptake on the app, the government was, the state government was able to contact trace people in a very good way. So I think as we go forward with the second wave, now obviously it's not as serious as the first wave in terms of the mortality, and also the people who are going to ICU, as we see them, the age group is going to the younger group side. I think maybe because the new group that have been confirmed in the second wave are younger generations, maybe the uptake of the app might be a bit higher in that generation, thereby the app itself might be a little bit more effective as we go ahead. Just one thing I want to mention about the presentation, the Norwegian case was quite interesting because it mentioned about how the government was dealing with migrants and also with minors and how to address mental sort of issues, but especially the migrants and foreigners part, because if we look at Australia, one of the first things that the Australian government did was to have non-permanent residents or citizens try to leave the country. So as there's going to be another lockdown, how countries are going to handle non-citizens or non-permanent residents? Are they going to be banned from entering? What are, the families are being split. What's going to happen there? I think that's an interesting part. We haven't had that serious discussion yet, but I think that could be something that we should have an eye on. Right, thanks.
Thank you, Duan. Ayman, would you like to share some questions from the participants, please? A couple.
Yes, okay, so thank you all for your questions. I think 2 questions already were answered about the centralization versus the decentralization. So I will move to a question by Pablo, quite a big question. He's asking, can we know at which point each country has lost the control over the infection numbers on this second wave?
Yeah, good point. Probably I would ask Richard in this order to briefly comment. Richard, Darren, definitely Manuel, we are, you know, among the countries that clearly where clearly contact tracing has been problematic. So would you like to comment, Richard?
Could you just repeat the question? I just
So at what point basically in the second wave,
right,
there was at a local or national level a loss of control over the contacts, the tracing,
yeah. Thank you. Sorry, I got the full question now. I think the loss of control in the UK started right at the beginning. It started right in March, when we effectively allowed people to come back into the country from places like Wuhan and Italy. I know I'm not trying to point fingers, but they came back from already well-known infected areas and were allowed to wander into the country again and get on with their lives. And we did not at that stage do contact tracing, and we did not test and trace. If we had have started to look at those cases and contain them as the other countries have done, perhaps more centralized, non-libertarian countries, we might have been able to curtail some of the outbreak and how fast it spread. We were very lackadaisical on testing and contact tracing people, and we've only just started to catch up, but it's too late. I think it's too late.
Yeah, well, I take your point. And Darren, you want to add something?
I'll completely agree with Richard. Is that I think the lack of testing and tracing, and I think even coming out of the first lockdown too quick, and I think that gave the impression as well to the general population that everything was okay now. And I think that precipitated a big change in people's behaviour, and I think a lot of people become desensitized to the pandemic at that point.
Yeah. Please, Manuel, you want to add a quick comment about this in Spain, and maybe that is also the case for Italy. And Jonathan, please also step in. One of the things that is surprising is that there was a lot of emphasis in Italy in particular after the so-called first wave in contact tracing, and when cases started going down and the infrastructure seemed to function, everybody believed that contact tracing could actually function, and it actually didn't, although the testing is extremely high. In countries like Australia, it has worked incredibly well. So any comments, Manuel, for what happened in Spain? Because it seems to have been sort of a missed opportunity within the contact tracing space.
Yeah, actually, thank you for the question. It's a really good one, and also I perfectly agree with Richard and Darren in their comments. I think that with respect to March, it was completely chaos what we had here, because we didn't have any tests. Actually, now the difference is that we do the test, and we do many tests, and still yesterday there were more than 300 deaths in Spain. So that's a terrible numbers. And basically, I think one of the points that we are not doing in Spain is the tracing. We do have the apps, so the technology is there, but most people are not downloading their mobiles, their app, and we are not using that. And actually, that's a big problem, because even if we do have the tests, we still are not using the way in which we could avoid the risk of being infected. And well, actually, we are already in the second wave, and we'll see for how long it's going to be like that. Okay,
Jonathan, Shuli.
I mean, I wanted to make a comment about the UK too, because I'm living here. One of the things that's distinctive here is the lack of expertise that's been deployed in the track and trace system. This has been privatized to very limited people with very limited training, and so the fact that it exists is it reinforces the lack of trust in the process if you know that the people you're going to talk to don't know anything. So I think that's been part of the problem. The second point I wanted to make is that the response to the second wave is as much to do with looking at what other countries are doing as it is responding to what's happening domestically. So I think certainly both in Norway and in the UK, seeing France go into hard lockdown has prompted policymakers to do that. Though in Norway, what we've seen is an increase coming into the beginning of September, and then it's just spiked here at the end of October. So I mean, it is responding to a real thing domestically, but I think it's shaped by broader European policy responses.
Francesco, can I add something?
Absolutely.
Yeah, okay. So here, our second lockdown was before the government lost control. It was because they were afraid we came to the period of the Jewish holidays, and they were afraid of the interaction, the family interactions during the holidays. So that's why they decided to put the country into lockdown. But then what people did, they just, because of the lack of trust, and maybe this is the next issue that we could discuss, not today, but maybe in another day. It's the lack of trust in the policymakers really affect the pandemic here in Israel, actually, because people, what they did, they just cheat. Because they knew there were going to be a lockdown during the holidays, they did the family dinners before. So this is crazy, right? So that's it. That's the point I wanted to make.
Fantastic. No, you're right. Ayman, you would like to go with the second and final question, perhaps, for our...
Yes.
Yeah.
So probably, yeah, we have a final question from Ray, and he says that it would be interesting, Bragg,
okay,
if I'm pronouncing it rightly.
Brage, so I think Brage is from Norway.
Yeah, it would be interesting to hear different point of views on the controversial Great Barrington Declaration. So basically, the Great Barrington Declaration was declared in the US, and it's more about adopting a focused protection strategy and minimizing the societal harm for people at low risk, to allow them to go on with their lives without or with minimal lockdowns and mitigation policies. And the target is maybe to go or build herd immunity.
Okay.
So in the absence of vaccination or solution, yeah, what is the takes on this? What are
maybe I would like to ask Andrew.
I think the best person to talk on this first, Francesco, is Matthias, who sent me a little brief on that.
No. I think Matthias has left, but no, I want to hear your opinion, and let me contextualize it. So Australia has chosen, more or less implicitly or explicitly, I leave you the semantics, a strategy that it's pretty much trying to achieve elimination, right? I mean, this is clearly the objective, right? The risk with that strategy is, of course, it's contingent to vaccination and effective vaccination. Otherwise, there is no point in having being in full isolation and exploiting, if you want, the geographical and density characteristics.
Right.
It makes a lot of sense to take that approach. So obviously, when you hear a proposal like that it's more probably, adaptable to, let's say, more connected and densely populated nations, what is your feeling or reaction? Would you consider trading off the costs and benefits of prolonged isolation with the benefits, perhaps, of increased freedom, given the uncertainty of a vaccine?
Yeah, well, this is a trick question in some ways, because I'm not an expert in the Barrington brief itself, but let's look at what you said. Would you use the word trade-off or, and I think once we slip into that, if you're in a meeting, it's lives or livelihoods, it's the economy or it's deaths, you're already in trouble, right? Because we have to do both. We have to look after people and we have to have a sustainable livelihood. So the minute you're in a meeting where it's this devil's choice between either or, you automatically should have an alarm that things are going off. And if I flip back a question, Eamon, the one you asked, when have we lost control? I could have added, when have we lost control of it? Well, what is it? Like, what is the Great Barrington Declaration trying to deal with? And to me, you know, I would go back to step one. It's got some good things, but it doesn't have a clear goal, right? So what do I mean by loss of control of it, Francesco? Well, is it elimination? Is it not having any infections? Or is it not having any deaths? Or is it controlling aged care? Or is it keeping ICU not from being overrun or the health system being overrun? Or is it the economy? And I think it's very easy to step into, and we just did it, right? When have we lost control? Of what? You know, I think we have to challenge ourselves to what is it? What are we losing control of?
Good.
You know, that's
very good point.
So before I can, you know, you even did it then, you said Australia's got into elimination. We've never had that debate. I admit we have got to that, and we can do that as an island. But I don't think we've had that debate, and we need to be very careful about getting into this trade-off thing.
Correct, yeah. So maybe Jonathan, and then we can conclude. I would like to hear your thoughts on this.
Well, I mean, I think that, again, this is a trick question. I agree. Because really what we're talking about is individualism versus collectivism. And the assumption that individuals are in a position to make this decision assumes that the distribution of perceptions of risk, knowledge of risk, and appetite for risk are equal. And secondly, there are big social context factors. So the density of the local population, the household composition in which you live, all of these make significant differences to this. So I think it's crazy to say, oh, well, we'll just let people decide whether or not they're willing to risk being infectious, because it's not the risk to them which is the problem. It's the risk they create for others which is the problem. And that's the internal fallacy in this declaration, as I see.
Okay, very well. I wish really to bring it to a closure. We extended the effort by the presenters and the panelists. I thank them very much for the participation. Once again, a lot of the papers that we presented today were part of the Health Policy and Technology Special Issue. You can find the information about the network VIP and the issue on these links. And of course, if you have any questions about what we do at Newcastle, you can contact us here and we'll put you in contact with the network. So Ayman, I pass the torch back to you. Thanks everyone for participating and contributing.
Thank you, Francesco. I would like also to thank our dear presenters and our panelists. Thank you so much for your contribution. We will share with you the recording of this session, maximum by Monday, I would say. Up next in 2 weeks, on the 20th of November, we have our third and final webinar with the VHEP group. It's going to be interesting because we are going to discuss emerging countries and the COVID-19 in some countries in South America, where they experienced COVID in a different timeline, in a different situation. So yes, on the 20th, we will meet again. We will share with you the invitation. We are looking forward to see you in 2 weeks. Thank you, everyone, and have a good day or evening.
Thank you.
Bye. Thank you.
Bye.
Bye, everyone.